Welcome to the Rehab Hub Glasgow 3D gait analysis for our staff. So welcome to this training. My name's Sarah Jane. I'm the Clinical Director of the Rehab Hub Glasgow. And in this, we're going to go through 3D gait analysis, how it can help your patients, who it's for, what kind of patients it's for, and how does it work. So we are the only clinic in Glasgow to offer infrared 3D gait analysis, the gold standard in gait analysis and human movement. It will be the only gait analysis that will be approved by any health insurance. No other gait analysis system will be approved for health insurance purposes because they are not gold standard. The standard of this gait analysis would normally only be seen in research hospitals and in research labs. So we are cutting edge in bringing our clients something that's really new. So many of you working with us, you'll either be a physiotherapist, you'll either be a podiatrist, maybe a sports therapist. You will have done some base training at university on gait analysis or posture assessment. It's something that won't be new to you. Some of you will be more experienced. This training is to bring us all up to speed and get you confident with the Run Walk 3D system that is out of Oxford University that we're in partnership with. So what I want you to do, grab a bit of paper and a pen. Feel free to pause this video, and I want you to look at this person on the treadmill and imagine this was your client and you were analysing their running. I want you to notice, look at their shoulders, look at their head, look at their hips, look at their knees, look at their foot and ankle, and just jot down on that bit of paper what your observations are. Okay, now that you're back, what you may have jotted down are things like you may have thought, okay, maybe there's some over rotation of the left shoulder. Maybe you see a little bit of a pelvic hip drop or a hip drop, or is the shoulder, is that just that client's shirt that's in the way? Is it a valgus knee? Is there a foot pronation? Can you actually see that? And the foot progression angle, can you actually see it? And the reality is that you'd be subjectively guessworking here. When you're getting a 2D gait analysis, which most gait analysis systems are, whether that's in a running shop, whether that's in other private practices, they're usually using maybe a front and a back camera. So you've got sagittal plane and frontal plane motion being analysed. And they're maybe using an iPad, or they're maybe using some Logitech cameras. But the reality is that it's 2D gait analysis and it is subjective and not very accurate. Not to mention that when you are running, the foot is only on the ground for approximately 0.3 seconds. It is very difficult to subjectively observe all of those joints at that speed just by the naked eye. Even if you're slowing down video footage, it just isn't possible. In comparison, this is the data that we pull out of a Run 3D assessment. This is what we as clinicians will be seeing when our patients are being analysed by Run 3D. So you can see on the right-hand side here, we've got pelvic motion, hip motion, knee joint motion, and the ankle and foot motion. And we can see there's some parameters on the left-hand side where we're looking at cadence, step width, vertical excursion, and overstride. Now you can see there's a little blue triangle that's representing the left side of the body, and the red dot is representing the right-hand side of the body. And what you'll notice from here is that if you just look at the pelvic motion, which is the top one on the right-hand side, you will see pelvic tilt, pelvic obliquity, and pelvic rotation. So you've got sagittal plane motion with the pelvic tilt, pelvic obliquity, you've got your frontal plane motion, pelvic rotation will be your transverse plane motion. So we're measuring 3D environment. So what I want you to notice here is if I just click through, this should just take it. Yes, so we can see where I've just circled here, you can see on that pelvic rotation, you can see on the right side is sitting higher with more rotation, and the left side is sitting on a lower side. So this would give us an indication that this person is driving and rotating more through their left side with more stability through the left side. We can also see, if we just click through, if we go down to the hip joint, we can see that there is internal rotation. So something's happening in that right side where there is less internal rotation on the right side of the hip, and we have a higher internal rotation sitting within the mean value for the left-hand side. And then if we go down to the bottom, foot and ankle, we can see inversion at foot strike. We can see that bilaterally, left and right side, primarily slightly more on the left side, we have high inversion at foot strike. So we can see immediately, just even looking at this, even though this might be your first time looking at this sort of data, that we have this really nice in one place where we can accurately get the joint motion, the kinematics, all at the same time, all analysed and see exactly what's happening. This really allows us to objectively look at this and work out exactly what's going on with our patients. So you've got somebody coming in with back pain, hip pain, lower back pain, knee pain, ankle, foot pain. This allows you to problem solve and work out why they are getting that pain output, or maybe why their tissues are responding in the way that they are. So what is 3D gait analysis? So 3D gait analysis is the most accurate assessment of walking or running motion. It's used predominantly in research and in specialist orthopaedic hospitals. It's an effective investigation for treating musculoskeletal pain. Run 3D gait analysis is basically bringing the technology that out of the research laboratory and into everyday clinical practice. And that's what we have here in Glasgow. And it allows us to help get our patients out of pain. The main differences between 3D and 2D. So let's look at these, because these is really important that our patients understand the differences in what it is they are actually getting. So on the left-hand side, we have the 3D gait analysis. On the right-hand side, we have the 2D gait analysis. Probably the most important and probably most obvious for us is objective and subjective. So your 3D gait analysis is objective. 2D gait analysis is guesswork. It's very subjective. It's very much down to that clinician's expertise. It wouldn't stand up at all in research. So from a research perspective, it wouldn't be used. That research would just be flung out as it's not of good value. And what you will find is with this sort of analysis, you could have the same person be analysed by 2, 3, 4, 5 different people, and they would get a different result. And that really is the difference. Whereas our 3D gait analysis is objective data, it's precise, it's gold standard clinical-wise, gold standard research-wise. It's what's used in orthopaedic hospitals. It is the gold standard. It is not guesswork. 3D gait analysis uses motion capture technology used in research. So we use infrared cameras to determine the joint lines and to measure movement kinematics. Whereas your 2G will essentially, it's slow motion technology. So essentially what most people will be doing will maybe be using their iPhone, maybe using an app, maybe an iPad, or maybe using Logitech cameras that are linking into your kind of software to kind of slow it down and try and look at it. But again, it's again very subjective. So when you look at the 3D, we can analyse 4 joints simultaneously, so that in the previous slide that I showed you, whereas on the 2D, it's less informative report. It's harder to look at several joints together. With our 3D analysis, Oxford University have provided us with a way that we can extract that data very nicely for our patients, or for our other allied health professionals that we're working with, where they're needing that data to help rehab their patients. We're able to get hold of a really nice, really simple report that allows that patient to go away pretty much same day with the findings. Whereas when you've got 2D analysis, the reporting might take longer. It's probably less, it will be less specific. The big difference, though, is in cost. So 2D analysis, most of your patients will have maybe gone into a running shop or somewhere and they've put them on some scanner because they're selling them some pair of shoes. So they'll feel as though they've had a gait analysis. They haven't. They've had a quick, very subjective look at them to guide them into what type of shoe or running shoe would be better for them. It is a very simplistic, a very subjective way of analysing. So many people might have had a gait analysis and they would think, oh, that I got that free at the running shop. Whereas our analysis is a cost, the cost is higher. So our patients will be paying at least £160 for the starter gait analysis without. It is a lot more expensive, but it's almost like comparing white and black. It's completely different. Okay, so we're going to look at a 3D gait analysis happening. So hopefully this will just play. Let's see. There we go. This is what happens during a 3D gait analysis. Now, we will be going through this in person in clinics. So you can see we're putting on the markers here, getting the patient ready to be put into the 3D environment. We stick on at the joint lines near the knee and down at the medial and lateral malleolus.
Hi there. So the first thing I'm just going to explain is the markers that we have set up here on the patient. We have two different types of markers. We've got clusters that go in the backs of the thighs, the calves, and the pelvis. And then we've got individual markers that go on the joint lines, on the knees, the ankles, the front of the hips. And then there's also some clusters in the backs of the shoes.
So that's the patient basically all put up. We then collaborate the system. So we're creating the 3D environment here, telling the 3D cameras where the space is. We then do a static trial.
All right, so now what we're going to do is take a static trial of the patient. He's all set up onto the treadmill, ready to go. I'm just going to come over here. We're going to click New Static, and it's ready to go, and everything's labeled. And what you can see here is he's into a nice little skeleton, and we can see that everything looks really good. So Mike, if you just bend your knees for me, please. Good. And again, march him down on the spot. Perfect.
So that's them in the 3D environment. And then we analyze.
Okay, so now we are collecting a walking trial. And we're going to just select capture here. And it takes 30 seconds to collect a trial of somebody walking or running, and you can select different speeds of running. And Mike here, client, is just walking at his normal speed. He's got some of his markers off, and he's looking at what's happening on the screen here. And so we're just looking at all the different things that can happen on the assessment. And this is going to finish up here. There we go, and that's completed. You've got your full trial collected. We click save. Anything you want to write down that was different about this trial. And that's it, and that's done. You've done your complete 3D gait analysis.
So that is that done. And then from here, we would then go into producing the report. This is what the report looks like for the patient. This is the traffic light system. It's quite nice and tidy for them to able to easily go through. And then as we come down, we've got the MSK assessments. This is what this is here. So that's all the results of that. And it tells the patients nice and simply what that all means. And then down the bottom is what we would look at. So this is the key parameters that we showed you earlier. So it really gives you a nice and easy, and it gives you in many different ways, whether you like stats. So if you like all the stats, they're all there. If you like the clinical parameters presented on your dot chart, you've got it there. And you've also got all the stats and the figures and your kinematics there as well. So how does Run 3D actually work? Okay, so we kind of spoke a little bit about this. So we use infrared 3D cameras. The cameras are actually called Vicon, and these are a state-of-the-art company, the same company that basically use for making your motion pictures. So your big Hollywood pictures like Star Wars and things. It's the same company, same cameras. This is what we're using. We obviously market up the patients as we showed you. We put them into that 3D environment. Then another part of our 3D and gait assessment is the objective tools to accurately measure your musculoskeletal system. So you can see on the left here, this is Andrea doing some tests, MSK tests, which will show you what that looks like. So the science behind what's happening. So if we start from the left and work our way to the right. So we've got the infrared cameras that capture 3D the 3D positions of the markers. The markers are placed on the patient to create the computerized model. You can see that computerized model where they've got the 3D joint kinematics. And then from there, the foot strike at toe off is identified and the discrete parameters extracted from the kinematic curves, and then the patient data is compared to a database of uninjured controls. So that's the science behind what's actually happening in the back end. How can Run 3D help our patients? How, if you've got patients coming in, what can it help them with? Who is this for? Why would they need to do this? So it can help them with any, move injury free, reduce pain, move faster, stay active, increase their fitness, prevent injuries, and reach their goals. It really is that powerful. So if we've got patients that are in pain and we want to know why they're in pain or how they're loading those tissues, we might have some patients, for example, with Achilles tendon problems, why is the tissues responding that way? Or maybe they've got first signs of osteoarthritis, or maybe they're wanting to go and do a run faster. Maybe they're training for a couch to 5K, maybe it's a marathon. It can help all of these things. Also preventing injuries. So if you're wanting to maybe go from couch to 5K, it would be brilliant to do this prior to starting your training and get a proper plan in place so that you know exactly where your weaknesses are and what you need to work on to get you up to the level that you want to be. So the types of patients that we identify that need this sort of analysis. So when you're working in clinic, you need to think about what is best for that patient. So if we can help, how can we help them best? We need to understand why that patient is in pain or why they're loading their tissues that way. That is our responsibility to figure out why. If we are only treating the symptoms that the patient's coming in with, we're doing them a big disservice. So we must ensure that what we are doing is that we are trying to problem solve and work out why that patient's tissues are responding in the way that they're responding. That is our job, not just to treat a symptom. So if we're just doing laser or shockwave or injecting therapy or just doing rehab and we're not taking into consideration why that patient's tissues are responding that way in the first place, then I don't know what we're doing, right? So that is, and unfortunately, that is the reality of what's happening in most clinics is patients are just getting treated for symptoms and the actual cause is not being addressed or identified. So it's indicated for any overuse injuries, patients with recurring injuries, multiple injuries, pain that they can't diagnose. Brilliant. We always get the patients that have been around the houses, loads of other clinicians and clinics and getting nowhere. Also great for patients who are unable to train due to an injury, or they maybe want to start a new exercise program, or they've got a big goal that they want to achieve, they want to do a marathon, or they've got a big training event, or they're post-surgery, so they've maybe had a hip replacement or a knee replacement or some other surgery and they want to avoid a compensatory injury. Also great for prehab, so before you're going in for surgery as well. Oh, slipped a slide there. So it's important to mention that we don't only have available in the Rehab Hub to our patients just the gait analysis and the MSK. We offer a whole selection of services for our patients depending on their clinical presentation and what they need. So the first one on the left here is MSK testing. So we could just do an MSK analysis without the gait analysis. Might find there's maybe some neurological issues that you want to identify, or you might find that you just want to check strength or functional movement patterns, then you could just do the MSK test just on its own. That's all within the Run 3D package and there for us to do. The next level up would be your silver gait analysis. Silver gait analysis is just the gait analysis for the patient. So they would just get that 3D environment gait analysis with no MSK. The gold analysis is the silver analysis and the MSK together. So basically they're getting the full 3D assessment and the MSK assessment as well. But we could also do fatigue testing. So if you've maybe got a patient that's coming in that's maybe fatiguing on 12 mile, they're maybe training for a marathon, we could absolutely identify what's going on, the associated structures that need to be worked on to help them get over that. We also have a great Gait retraining program within the Rehab Hub. So many of our patients are coming and getting Gait retraining monthly. So they've been in, they've had their possibly silver or gold Gait analysis. They're maybe training, they maybe enjoy training a recreational runner, maybe enjoy doing marathons, or maybe just enjoy doing 10Ks and want to just keep they want to improve their running style and reduce their likelihood of injury. So Gait retraining is amazing for that. And what we do is we get them on the treadmill, we get them all markered up, and we actually real life time start to change stuff. So we can, say for example, they had a reduced cadence. We start to work on the cadence and see how that actually affects those key parameters. We might be working on step width, it might be anterior pelvic tilt, it might be hip, it might be internal rotation. Whatever it is we're working on, we can real time start to change these things, but in real time, see live how that affects the parameters and what that then does to the system. Really, really powerful and amazing for clients to have, because it means that they can then put that into practice in their own training. And usually with a Gait retraining program, we'd usually see patients initially for an analysis and then 3 further Gait retraining sessions. Other things that we can do is orthotic comparison. And this is something that actually industry-wise is terrible at. It's just nobody does it. We give patients out orthotics, clinics all over the UK and elsewhere, and off the pop, and that's it. Are we actually looking at if they're doing what they're meant to be doing? Okay, yes, we put a prescription in, but is it actually doing what it's meant to be doing? Are we reassessing that? Are we testing it out? Probably not. I would hazard a big wild card guess that most clinicians are not doing that. They'll just go on what the patient's saying. Now, I'm not saying that doesn't have a massive significance. Of course, it does. But if we want to check or is it better with the orthotic, or is it better without the orthotic? It's a bit, we can real time analyze the orthotics. Many patients might be using different orthotics for different things. So we can look at how that changes the load onto the tissues to see if it's actually going to do what we want it to do. Really powerful. Also, we can do shoe comparisons. So putting our patients into different styles of shoes, getting them on and seeing real time the parameters and how that shoe style actually affects their gait and their kinematics. So not just gait analysis, we've got lots and lots of options there for our patients. Okay, so let's look at some testing in the MSK and what happens. Andrea's going to show us here.
Position the client in side lying with the involved hips superior and the shoulders and pelvis perpendicular to the table. Flex the uninvolved hip to approximately 20 degrees and the uninvolved knee to approximately 90 degrees. Ask the client to grasp the edge of the examination table with the upper arm in order to stabilize the trunk. Position the involved leg into approximately 30 degrees of abduction, 10 degrees of hip extension, and neutral hip rotation. Place the handheld dynamometer proximal to the lateral malleolus and apply a resistance downwards. Instruct the client to maximally abduct his hip in order to prevent you from pushing his leg down towards the table. Monitor the movement to ensure no hip flexion occurs and stabilize the pelvis with the free hand.
Okay, hold your leg there. Don't let me push you down. Push up.
Perfect. So that's just an example, Andrea, showing us how we objectively gather data in the MSK assessments as well. It isn't just guesswork and saying, oh yeah, you're strong there or you're not. So we do lots of functional tests. We'll also use things like goniometers and are measuring our peak force to actually measure the strength within our key muscle groups. Right, when we are building out, so after they've had their analysis, we've done their MSK, where do they go now? What do we offer patients? What's the next step? It totally depends on your patient, their clinical presentation, their goals, what they need, how much support they need. But what I can assure you is that part of your plan for your patients will be a strength and conditioning rehabilitation program. That is a absolute hard, that will be in it. I cannot think under any circumstances where that would not be indicated. So that will be part of the program. Now, bearing in mind that some of the clients that are coming to see us have been referred over maybe from orthopedics, maybe from their GP, or maybe from a physiotherapist that they're currently working with, osteopath. We've got partners all over Glasgow that refer into us so that we can do the analysis, and then we send that analysis and report back to their healthcare practitioner. So bear that in mind, that we won't always be taking the lead on their rehab or any other therapies that they have. So it's important that we include in the report to the healthcare professional the key areas that patient needs to be working on, so that they're able to pick that up. But strength and conditioning will be part of that plan for your patients, whether it's us or whether it's external. Hands-on treatments, modalities, manipulation, soft tissue therapy, all of these things, whether it's dry needling, massage therapy, we've got all of that in-house as well. So these things, remember, are there as an option for your patients. So if you think they can benefit from that, build that into their management plan. Remember, this is about what is best for that patient, what's going to get them from point A to point B. But remember, be ethical with that. Don't be offering things that they don't need. So don't just think, oh, we'll just throw everything in there. Make sure it is indicated. Make sure it is in that patient's best interest. Don't just put it in because I have no idea, like you think, well, that'll be good. Just put it in if it's something that is going to be of benefit for that patient. We could also look at orthotic prescription. Again, ethical prescribing. Make sure that is something that they're actually needing. But it is something that we could do. We do that in-house. We can make them in the clinic here in Glasgow. We would, if indicated, we'd be offering shoe advice, trainer advice, whatever it is they need. And onward referral. Now, we've got physiotherapy here, we've got podiatry here, we've got sports therapy here, we've got rehabilitation, we've got a Pilates reformer. We're really lucky. We have that big multidisciplinary clinic where we're all there under the one roof. So that is really unusual. So use it to the best of your advantage. So make sure that, say, for example, you are one of the sports therapists with us, make sure that you are collaborating with our physios and our podiatrists when you're maybe collecting this data, and it's then being referred back over to the physio or to the podiatrist to continue on with further modalities and treatment that are out with your scope of practice. But stay on top of that, like learn from that. Don't think, all right, I've sent that to the physio, so that's me. I'm not part of that anymore. You absolutely are, but it's knowing that there's these referral pathways there. One thing that we absolutely pride ourselves on within the Rehab Hub Glasgow is that multidisciplinary teamwork, knowing where our strengths are and knowing what your expertise is, and making sure that you do the best for that patient and you're passing them for what they actually need, and you're not kind of keeping them all to yourself. So somebody, if they would benefit from seeing podiatry, if they would benefit from seeing and doing some sports massage therapy, then we refer that on to the appropriate professional for that within the Rehab Hub. We've got everybody there. Now, on the same side of that, remember, there will be our colleagues out within Greater Glasgow that we're referring that back to. So we might be referring into osteopaths or external physios or podiatrists, orthopedic surgeons. So just bear all that in mind, and that you're keeping everything that this is all about, working multidisciplinary and working for the best clinical outcomes for your patient. Other things that we could do are Gait retraining, that spoke about a wee bit earlier, so I'll not get into that too much more. And then also all the other treatment options, so things like shockwave, things like laser therapy, dry needling, cupping, soft tissue, all of those things, Pilates. We're so lucky we've got all of that in-house. So just make sure that when you are building out the treatment and rehabilitation programs, that you bear all that in mind, and you think and you link that up into what the patient's goals and expectations are. So keep jumping through slides here. So this is a little case history. So let's go through this. This is a Achilles tendinopathy, something we see quite a lot. So bilateral Achilles tendinopathy, a 47-year-old long distance runner and triathlete, male. And Okay, so on the left-hand side, we've got the key parameters, right? So this is the results that we found from this particular patient's 3D assessment. And let's talk about what the main key points here that we've picked up on this and what that's then meant for the rehab. So we can see that it's an ankle dominant gait pattern. They've got reduced hip extension and excessive anterior pelvic tilt. Okay, we can see it within the control planes. We can see that there is hip asymmetry, both transverse plane and in frontal plane. They're overstriding and they've got reduced knee flexion and reduced cadence. So the rehab program based on these findings included gait retraining, and this was to increase knee flexion and increase the cadence to improve the overstride problem that they've got. So that meant they're coming in on a monthly basis. They've got their rehab program with it as well. So they've got the strength and neuromuscular control rehab, but they're coming in on a monthly basis to work on that knee flexion. So the strength and neuromuscular control, pelvic tilt control, and increased functional gluteal strength and hip extension, targeting the hip adductors, hamstrings, glutes activation, and single leg squat control. Flexibility, key areas that we were targeting with this one is hip flexors, quadriceps, and calves. And the outcome is that the patient is able to get back to following initial gait retraining and advised home exercises and physio with 1 month follow-up and review gait changes. Okay, so normally in this sort of presentation, we would see this patient back for a further 3 sessions. That's kind of a general standard protocol in our clinic for doing gait retraining with them. So we'd see them after their initial assessment, we'd see them further for 3 months after that. But the rehab program usually would be within that. Obviously depends if we're working with referrals out, then they would be doing the rehab, but we would still see them back for that gait retraining session. So I hope this has been of value to you. I hope that this excites you, having access to this sort of technology and really state-of-the-art equipment and training here in Glasgow. And I hope that not only do you take the training on board, we don't expect you first time looking at this to be an expert at this. You're not going to be. Initially, as you're working with us, we will get you getting used to the system. You'll not be expected to analyse this system right away. That will be a clinical lead, it'll be myself. And those of you who really take an interest in this and want to go. But I want you to run with it. I want you to read around it. Any questions, remember, come and speak. There's always an open door, always happy to answer questions. And yep, happy running, happy gait retraining. See you all in clinic soon.